So we'll talk about screening for pancreatic cancer, who and how, but first I want to talk about the why. And I won't belabor this audience and go through why pancreatic cancer is bad, because I think we can probably universally agree upon that. But I'll go through some of sort of the risk assessment and an understanding of some of the background for why we would screen for pancreatic cancer, go through some of the data on how we do it, and then towards the end, I'll get to some of the guidelines, which have actually just been updated about 3 days ago. So these are my disclosures. Apart from the grant support that was already mentioned, also received some research and consulting support from a few industry partners. The learning objectives for today are to define individuals who are at increased risk of developing pancreatic cancer. And for today, I'm going to really focus on pancreatic ductal adenocarcinoma and not neuroendocrine tumors. We'll talk about who might be a candidate for genetic testing, and we'll talk about an appropriate surveillance strategy once we've identified these high-risk individuals. So I'll start with a case. This is one of my patients. When I first met him, he was 74, and he just sat down in the office and said, my sister has pancreatic cancer at 68, my brother has it at 78. I don't want pancreatic cancer. What can we do? So at that point, I talked to him about what the risk of pancreatic cancer might be. And it turns out that probably about 10 to 15, and some would argue up to about 20% of pancreatic cancer actually has some sort of familial aggregation or inherited predisposition. And so the group at Johns Hopkins has been the group that's really looked at this over the longest period of time. And over about 20 years ago, they published their first reports about risk of pancreatic cancer based on the number of first-degree relatives in comparison to the general population. And that's what we call a standardized incidence ratio. A first-degree relative is someone who's just kind of one step away from you on the family tree. So that's a mother, a father, sister, brother, or sometimes even a child. And it turns out, if you have one first-degree relative, the standardized incidence ratio for developing pancreatic cancer is about 4.5. But if you look at the confidence interval, it's both very wide and crosses 1. And so this is not statistically increased, and it's probably a pretty heterogeneous population. But once you have 2 or more first-degree family members with pancreatic cancer, then your risk of pancreatic cancer is significantly increased. And this has come to be known as familial pancreatic cancer. So familial pancreatic cancer, or FPC kindreds, are families who have 2 or more affected family members who are related in first-degree relation to each other and have been affected by pancreatic cancer. The Hopkins group has actually gone back and looked at their data over 20 years later and looked at the incidence of pancreatic cancer not just by the number of first-degree relatives who have been affected, but also in these FPC kindreds by the number of first-degree relatives. And you can see they have a huge number of patients, over 8,000 patients with 70,000 person years of follow-up. And it turns out that the number of first-degree relatives in the FPC kindred is sort of a dose response. So the more close blood relatives that you have, your standardized incidence ratio increases to the point where if you have 3 or more first-degree relatives, the standardized incidence ratio is actually over 10, extremely high lifetime risk. But family history isn't everything. And so we've learned over the years that there are a number of inherited syndromes that predispose to pancreatic cancer. And I'll go through them briefly here. There's the hereditary breast and ovarian cancer syndrome, or HBOC. We know about this from BRCA1 and BRCA2 variants that have a sort of modest risk of pancreatic cancer development, also associated with breast cancer, gynecologic cancers, prostate cancer, and melanoma. There's PALB2, or partner and localizer of BRCA2, so it kind of makes sense that it works in the same pathway. Modest increased risk of pancreatic cancer, also risk of breast cancer. There's ataxia and telangiectasia, which we might have learned about in medical school. If you inherit 2 copies of this gene, you have something called ataxia and telangiectasia. But if it turns out if you inherit 1 germline variant of this gene, you're predisposed to both pancreatic cancer as well as breast cancer. And then there's a few of the zebras that the gastroenterology audience is used to hearing about. So there's the FAM syndrome, familial atypical multiple mole melanoma. It's a mouthful. caused by germline variants in CDKN2A or P16, very high risk of pancreatic cancer, but also dysplastic nevi melanoma. Putz-Jaeger's syndrome, caused by STK11, relative risk of pancreatic cancer, you see this number everywhere, is 132. Also causes hamartomatous polyps throughout the GI tract, very high risk of breast cancer and some other cancers. And then we have Lynch syndrome, which causes a modest increased risk in pancreatic cancer, along with colorectal cancer, endometrial cancer, small bowel cancer, gastric cancers, and some others, caused by germline variants in the mismatch repair genes. We have hereditary pancreatitis, very, very rare condition, but associated with an increased risk of pancreatic cancer. And you'll often see familial polyposis, FAP, on this list as causing an increased risk of pancreatic cancer. It's uncertain if that's truly pancreatic cancer or just a misclassification of some of the ampullary cancers. But so these are sort of the genes and what I call the alphabet soup that you'll see for pancreatic cancer susceptibility genes. What if we look at it the other way? So let's take pancreatic cancer cohorts, unselected pancreatic cancer cohorts, and apply genetic testing to them. And so this is an example of just like 5 studies looking at a variety of different panels that you can see on the left, ranging from 13 different genes to 30 some odd genes, a variety of different cohorts, urban cohorts, American cohorts, Canadian cohorts, varying size, where they looked at the prevalence of pathogenic germline variants in cancer susceptibility genes in these pancreatic cancer cohorts. And what you can see is if you do genetic testing on unselected cohorts of pancreatic cancer patients, you can find cancer susceptibility genes in somewhere between 4 to 10%. And if you really enrich that to those who have a first degree or second degree relative with pancreatic cancer, then you see germline variants in up to about 13%. And then conversely, on the bottom, if you look the other way around, those who had germline variants, if you look kind of in the rear view, you can see that 21% of those actually had a family history of pancreatic cancer. And the genes that you see over on the right are largely the ones that I've mentioned on some of the previous slides. The group at the Mayo Clinic actually took this a step further. So not only were they able to sequence 3,000 pancreatic cancer patients, but they also sequenced 30,000 controls. And from this, they're able to generate odds ratios for risk of developing pancreatic cancer. So a little bit better data than some of the cohort data that I've shown you on previous slides. And what they see is that, as expected, CDKN2A, P53, which is Li-Fraumeni syndrome, cause very high risk of pancreatic cancer. And then we have this sort of modest odds ratios in the 2 to 6 level for some of these other cancer susceptibility genes. And I think it's important to note that for all of these genes, pancreatic cancer often isn't kind of like cancer number 1 or 2 that we think about. Oftentimes, really high risk of breast cancer, gynecologic cancer, colon cancer, and pancreatic cancer is something that seems to go along with it, but seems to be a much lower risk than some of the other genes that we're seeing. But the genes aren't everything, and so some of my patients will come to me and say, well, I have this gene, so it's all done, so here we are. But the genes aren't everything, and there's very clearly environmental risk that interact with genetic susceptibility to any sort of cancers. And so we have data on tobacco exposure, for example, for familial pancreatic cancer. And it turns out that if you have an affected family member with pancreatic cancer and you smoke, your risk of pancreatic cancer is actually 3 times higher than it is with the same family history but no tobacco exposure. And even if you dig into the data for some of the very, very high cancer susceptibility genes like CDKN2A, if you divide them out between ever smokers and non-smokers, you can actually see that almost all of the cancer risk is attributed to people who have the germline variants with a tobacco exposure. And so basically, you almost don't get cancer if you don't also have the tobacco exposure.